Hello, my name is Sean Strain. I'm Professor of Human Nutrition and Director of the Northern Ireland Centre for Food and Health at the University of Ulster. I'm here on our Coleraine campus in the Centre for Molecular Biosciences, and I'm about to interview Dr. Carl Wilson, who is one of our bright early stage researchers. Carl has just published a paper in the American Journal of Clinical Nutrition. Carl, why are your findings so exciting?
These findings are so exciting because they discuss a novel non-drug treatment for high blood pressure targeted at individuals with a particular genetic factor. The genetic factor of interest is the 677C to T polymorphism in the gene encoding the folate metabolizing enzyme methylene tetrahydrofolate reductase, or MTHFR. The MTHFR enzyme requires riboflavin vitamin B2 in its coenzymatic form FAD as a cofactor. And interestingly, our group first reported on the interaction between the MTHFR enzyme and riboflavin 10 years ago in AJCN.
Carl, the focus of your paper is on blood pressure. Has this polymorphism been linked with blood pressure?
Sean, well, several papers published as far back as 10 or 15 years ago have reported an association between the 677C to T polymorphism and blood pressure. However, these papers appear to have been largely overlooked, and it's not until more recently that two meta-analyses have come out reporting a strong association between the polymorphism and blood pressure that recent research activity appears to focus more on the impact of this variant on blood pressure. But given that previous studies have reported an association between the 677C to T polymorphism and blood pressure, no researchers outside of our group have considered the modulating role of riboflavin, which is needed as a cofactor for the MTHFR enzyme, and how this may modulate blood pressure in individuals with the TT genotype.
Great. How has the current paper advanced previous work in this area?
Well, the previous study that was conducted by Horrigan et al. At this centre in 2004, and what they showed was that individuals with the TT genotype had significantly higher blood pressure compared to those with the CC genotype. And they showed for the first time that riboflavin supplementation at the dietary level of 1.6 milligrams per day for 16 weeks produced a significant lowering of blood pressure, but this only occurred in individuals with the TT genotype. However, it's important to be aware that that study was conducted in 2004, and in 2006 there were significant changes in the therapeutic management of hypertension in the UK guidelines. These changes advocated a switch from one medication to multiple medications in order to achieve a target blood pressure. But they also removed beta blockers as first-line therapy with a preference towards other classes of antihypertensive medications. So given that there were significant changes in the therapeutic management of hypertension in 2006, this provided us with a unique opportunity to investigate the impact of the polymorphism on blood pressure, and secondly to determine if riboflavin could still lower blood pressure given that there were significant changes in the medication prescription over this period. In terms of procedures, blood pressure was measured according to the appropriate clinical guidelines, and this involved identification of the reference arm, which is the arm with the highest blood pressure. Two measurements from the reference arm were taken 10 minutes apart and the mean calculated. However, if there was a difference of greater than 5 millimeters of mercury in diastolic blood pressure or greater than 10 millimeters of mercury in systolic blood pressure, then a third measurement was taken, and the two measurements in closest agreement were then used to calculate the mean. Riboflavin status was determined by using ERAC, which is a functional assay that measures the activity of the enzyme glutathione reductase before and after in vitro reactivation with its prosthetic group FAD. ERAC is calculated as the ratio of FAD stimulated to unstimulated enzyme activity, with values at or above 1.3 generally indicative of suboptimal status. So whenever we actually analysed the results of this paper, what we found was that the significant changes in the therapeutic management of hypertension that were advocated we actually saw these changes in our data. In 2004, the majority of individuals were on either none or one medication, whereas in 2008 this had changed, with a greater percentage of individuals being on 2 or 3 or more medications. However, whenever we looked at medication use split by genotype, it became evident that individuals with the TT genotype were, at both time points, so in 2004 and also in 2008, they were more likely to be on 3 or more medications. We then decided to examine this further by looking at the blood pressure achieved, split by genotype, in 2004 and in 2008. And what we observed was that at both time points, individuals with the TT genotype had significantly higher blood pressure compared to those with the CC genotype. And this is despite the fact that, as I mentioned previously, they were more likely to be on 3 or more medications. In terms of the blood pressure response to riboflavin, we did the intervention in individuals with the TT genotype, whereby we swapped the treatment groups from the 2004 study. So individuals with the TT genotype that were given riboflavin in 2004 were now offered placebo and vice versa. And what we observed was that riboflavin was able to produce a significant lowering of blood pressure in individuals with the TT genotype, and that this blood pressure lowering response occurred irrespective of antihypertensive medication prescribed at that point.
How clinically relevant is the change in blood pressure which is described in your paper?
The blood pressure lowering response described in this paper is hugely relevant in terms of the clinical implications, and this is because even a lowering of blood pressure of around 2 millimeters of mercury can decrease stroke mortality by 10%, and that comes from a meta-analysis that was published in The Lancet, which included over 1 million individuals. So even a 2 millimeter of mercury decrease in systolic blood pressure lowers stroke risk by 10%. And in our study, we reported a blood pressure lowering in terms of systolic blood pressure of over 9 millimeters of mercury. So it's really very clinically relevant. It's important to bear in mind that many factors are targeted in order to lower blood pressure. Things such as weight loss or other lifestyle interventions such as decreasing alcohol consumption. However, other lifestyle approaches are notoriously difficult. And to put our results into context, it would take around 10 kilograms of weight loss to achieve the blood pressure lowering reported here. But one of the major strengths of our research is that we were able to achieve this blood pressure lowering in these individuals with the TT genotype by supplementing with the dietary level of riboflavin, so that's 1.6 milligrams per day. And what is very advantageous about this is you could optimise riboflavin status at the individual level, so it would have benefits to individuals who have the TT genotype in terms of lowering their blood pressure without having any harm to those individuals who do not have the TT genotype.
Finally, Carol, what are the implications of these findings in terms of the prevention and treatment of elevated blood pressure?
Well, these results could have significant implications, and the largest implications would be seen in countries that have the highest frequency of the TT genotype. So countries such as China and Mexico, for example, whereby the frequency of the TT genotype is up to 30%. Globally, the frequency of the TT genotype is around 10%, but it can be much higher, as I previously mentioned. The impact of this gene-nutrient interaction on blood pressure is also going to be largest in countries that have the highest frequency alongside the lowest intake of riboflavin. So they would be the countries that would be most likely to benefit from increasing riboflavin intakes. So we are hopeful that this and ongoing research by our group will shed further light on the role of this polymorphism on blood pressure and how it is modulated by riboflavin, as this could have significant implications in both the primary and secondary prevention of stroke, which is such a major killer globally.
Thanks very much, Karen.